All right, so I'd like to introduce your speaker for this session. His name is Peter Fifield. He's the manager of the Substance Use Disorder and Integrated Behavioral Health Services at Wentworth Douglas Hospital in Dover, New Hampshire. He's an adjunct faculty member at the University of New England as well. He has a doctoral degree from University of New England, is dual licensed in New Hampshire as a clinical mental health counselor and a master licensed alcohol and drug counselor. Please welcome Peter.
So we do have I have a lot of content that I'd like to get through. This is sort of like a high-level substance use disorder 101. So there is, I don't know if you're all aware, but there's a track this year, and I think it's newer, relatively newer, but there's much focus on it, of substance use disorders and how they impact individuals, influence brain injury, or interact with an individual with a brain injury, etc. So I'm here to talk about just the fundamental concept of substance use disorder, how we diagnose it, what are levels of care, treatment levels, what does care look like, and I think as importantly, what does readiness to access treatment, how does that influence? Okay, so we're not gonna, I never ever would claim to be an expert in anything. I've been doing this for a number of years, but I'm absolutely open to sort of interpretation, I want you all to be an interactive audience. How about that? Okay, because I know I might be an expert in one thing, but I'm not an expert in the lived experience. So, we'll start with that. I do have, was mentioned, I have dual license, so I treat co-occurring disorders, and that's another important thing that sort of we haven't done well in the whole treatment world. It used to be like, oh, you have a substance use disorder, you go over here, and then you get over there and they're like, oh, you have depression, you have to go back over there. And they're like, wait a minute, what the heck am I doing? Isn't it all right here? Can I go in one place? And it's very frustrating. So we're doing better at enhancing the sort of providing what they call co-occurring services. So I will start now. We're going to talk a little bit, like we said, about substance use disorders and very, very basic neurobiology, because Dan is going to talk about the way more sophisticated complexities of that later on. We're going to talk about the disease model of addiction and why it's important to sort of conceptualize it as within the disease model construct. And we're going to talk a lot about stigma and dignity, okay, just in general. So we're going to talk a little bit first about why. So why is this such a big deal? We are, as you all know, very familiar, most likely if you're exposed to any bit of news, we're in the middle of what they call an opioid epidemic, okay? Started many years ago. And something you don't want a silver medal in is this, right? 2015, New Hampshire was ranked second highest in overdose death per capita of any other state in the US. Ohio had the gold medal there, okay? So we were second in overdose deaths per capita, and this is related to opioids. Okay, very specific. This data piece, that's not super important, but this data piece, I just want you all to be aware of that. Now, in 2018, we were third. 2020, we were 22nd. Right? So you're like, oh my goodness, we're doing better. Right? Because this is something you want to do. You don't want the first place in, right? So we're 22nd out of 50 states. But why is that? And what we discovered was, so this is the 2015 map. Well, look at the dark colors here, because the dark colors are 21 to 41 deaths per 100,000. Okay? That's 2015, that's 2016, that's 2018, and the last time they collected all the data, that's 2020. So unfortunately, it's not because we're doing better at preventing it. It's because other states are underperforming preventing it, right? So interestingly enough, I bring this up because I think it's really important. The Substance Abuse and Mental Health Services of America and CDC and NIDA provide funding for individuals to prevent opioid use disorder per your effort and your ranking. Right? So even though we weren't really, as a state, doing better, we almost lost funding because it looked like we were doing better. Right? So just think about that, like losing funding to help prevent overdose death rates, even though they're not going down, but it's because other states are doing worse. Right? So they recalculated that, so it really isn't an issue in the end, but they had to really think about that to restructure the funding distribution. So this is a pretty decent snapshot of where we are now, okay? One of the significant issues, without a doubt, with this whole epidemic is this concept of fentanyl and carfentanil, right? 100,000 times stronger than heroin, not shining a shiny love light on heroin whatsoever, but when people were just doing heroin, we didn't really have the overdose rates that we have now with fentanyl involved. And xylazine is an animal tranquilizer. It is also generically, we'll just call it a sedative within the human physiology, so it does similar things as opioids in terms of like lowering respiration, slowing things down. So then you've got this really strong opioid called fentanyl slowing the human body down. Xylazine is slowing the human body down, and then just respirations stop happening after that. That's ultimately what the overdose death is related to. So that's really, those two collectively are the culprits here. The rate of drug overdose deaths involving synthetic opioids increased 22%, while the rates of death involving heroin declined. Right? So heroin, we're not dying, people aren't dying from doing heroin. Even though we generically call it heroin, it's not. It's fentanyl, which is another opioid. I don't want to mislead you in saying that. They're all opioids. But people aren't dying from heroin, really, like they used to. So that's drug poisoning. Now I'm just this is really kind of Debbie Downer talk here, and I apologize. We'll get into sort of hopefully some more optimistic stuff. But we're not just talking about overdose death rates due to opioids either. Overdose rates due to stimulants is increasing as well, right? And what happens with an overdose rate with a stimulant is really called overamping, or you're overheating, heart rate goes up, body temperature goes up, everything goes up, versus opioids where everything's going down, right? And a lot of times you mix those two things together and you've got one part of your body going up and the other part going down, the signaling's all mixed up. But people have been doing that, speedballing, for a long time too, right? That's not really a new concept. It's been very dangerous for a long time, don't get me wrong. But you start adding in fentanyl, carfentanil, very strong methamphetamines, and things are just like escalating to a point where sort of the human body is becoming less able to sort of tolerate what it's interacting with. So past year methamphetamine use, you can see the same thing with the darker colors. Really New Hampshire, interestingly enough, is really isolated in terms of drug and alcohol use behaviors compared to its isolated surrounding states. For some reason, New Hampshire's higher in tobacco use, alcohol use, marijuana use, other illicit drug use. It's just kind of a weird, the New England Journal of Medicine did an article on it, and they think it has a lot to do with the 95 corridor, the access right directly from sort of real influential spots in Massachusetts, right up through the New Hampshire Maine corridor, and the opioid epidemic. They blamed, I wouldn't say blamed, they identified that we had very, very, very few treatment options. We had the highest prescriptions of opioid per person in any other state in the whole US, right? That was kind of a lot that led to this back in the early 2000s. But we really do have, we're not the darker color. This belt here struggles tremendously with any use disorder and the overdose rates just in general. But you can see New Hampshire's gray, and I'll show you some slides later. We're just higher up than a lot of the states around us. Really, this is just kind of showing you that this was a massive increase, and I'm not here to preach abstinence. I'm not here to preach anything. I'm just kind of showing you the data in terms of where we're headed nationally. Marijuana use is spiked tremendously over the past couple of years, and there's a lot of individuals. Some people think that the spike, because it's so new being legal, the spike will go up and then it'll trend down again, right? Once it becomes more like, interestingly enough, a liquor store where there's a dispensary on every corner, it's sort of like, what are we weighing here? But there are sort of some thoughts that this will go down as the novelty of it, for lack of better words, decreases. This is somewhat optimistic, yet sort of in some ways it's kind of interesting to look at. You can see the opiates here from 2007, and they say opiates, right? They're a general class of opiates. So that could be anything from oxycodone, right, a pill that you're prescribed, to fentanyl that might come in a patch, or that you get illicitly, or heroin, or any derivative, even potentially kratom, which is a pseudo-opioid, kind of-ish, to methadone, to anything that sort of is in the opioid family. Increasing, right, you can see that all the way over here. Alcohol increasing. Interestingly enough, marijuana, according to this chart, nationally is going down, and cocaine's going down, right? They're sort of one of those, the easy to produce drugs. Methamphetamine is really easy to produce, right? So is fentanyl. You can do it in the lab, crank it out, you can do it. Fentanyl also isn't really all that new either. Used to call it China White, right? It came out of China. It was a really it was a common thing, but it's the way it's being mixed and the way it's being sort of incorporated and adulterated into other things is really the more dangerous. That's why it's becoming so dangerous. Looking at marijuana use just in general, this is a trend we like to keep an eye on, right? Marijuana use in the 12 to 17-year-olds is going up. Interestingly enough, in the older population, 18 to 25, it's going down. And 26, statistical significance really 1% increase, but not that much of an increase. But we do like to keep an eye on this trend here. So, the state that drinks the most alcohol in America per capita. Yes, we do. State of New Hampshire. Yep. So we bring this up because I really want to look at this for a second. This is just another statistic about individuals receiving MAT, and I think it's important. I'll talk about it a little bit because medication-assisted treatment, Vivitrol, which is an injectable, buprenorphine and its sort of derivatives like Subzolve, Suboxone, Sublocade, those sorts of things, they're effective medicines. They work wonderful. And for a long time, people were like, no, don't do that because if I'm displacing one thing for the next, and it was like, well, you might be replacing one pseudo-opioid in your body that's prescribed for one that's not, potentially might kill you, right? That is true, you're replacing this, but it's safer, and you can manage it over time, and you can sort of, so this is my big plea is to get people more on this because I think this saves lives, and the more days people are using a prescribed medication for their opiate use disorder, the less likely they are to die by overdose, period, right? So that's why I think this is a good intervention. But let's talk about this for a second, because in 2021, right, 106,000 Americans died as a result of drug poisoning. I heard something like the other day, that's 2 Vietnam Wars. That's crazy, right? I heard that and I was like, oh my God. It didn't really 100,000, I don't want to minimize that number. But when I heard 2 Vietnam Wars, I was like, I don't know why that hit me so hard. 25% of individuals in rehabilitation, right, are in rehabilitation, oh no. How did I do that? In treatment for brain injury are a result of drug and alcohol. So that could be an overdose-related, low oxygen-related injury to the brain. It could mean I was intoxicated, I fell and hit my head and received an injury from that. So it's connected to 25%. 50% receiving treatment for SUD have a history of at least one brain injury, right? So that's just like, I'm not going to talk a lot about that because we do have a wonderful presentation later in detail on that. I just wanted to connect this opioid epidemic and this sort of increased access and use of substances in general, connecting it directly to traumatic brain injuries just in general, okay? So don't need to see that. So let's take a pause here. So anyone ever heard of ASAM? American Society of Addiction Medicine. Okay, so it is a governing body that sort of really regulates diagnosis, treatment, levels of care, how care is accessed, things like that. It's a really important governing body. And they define addiction as a primary chronic disease of the brain reward, motivation, and memory system related to like circuitry, right? And there's dysfunction in the circuitry, basically because the brain adapts to having a substance in it And when that substance is not in it, it's like, wait a minute, I need that for survival, get it back. Okay? Literal neuroadaptive changes that happen in the brain that make that sort of a necessity and not so much just a, hey, it was fun kind of thing. Okay? So that's where that happens. When that happens, that's when they're talking about the disease model. Right? We're not talking about the disease model isn't really talking about the initial recreational use. I use it every once in a while and it's cool. That's not what I'm talking about here. It's with perpetuated habitual use over time with the maladaptive circuitry and neuro sort of patterning in the brain that says, this is no longer an option, I need this, not, I just want it, okay? So that's when we reach that disease state that medicine is now seeing as a reality, right? This is a chronic disease we manage. Has nothing to do with morals, right? Maybe you could argue it had to do with choice way back at the beginning, right? But we know Nancy Reagan's just say no thing didn't work, right? Look, everyone here tell me you've never made a bad choice, right? You can't say that. So maybe you could say it was a good or a bad choice way back in the beginning, but that's irrelevant once you get towards this sort of phase that we're talking about. The disease state is no longer a choice, right? It's no longer, I wish I was a better person. If I was, I could just do this differently. There's zero to do with that. Yes?
Sure. Just thinking about situations in my life and stuff, but with this too, can a lot of this start out as a mental health issue and kind of self-medicating?
Oh, sure, and we'll talk about that in a second.
Okay, sorry.
Without a doubt, that's a wonderful point, and I'll bring that up in a second, okay? So, this is out of the New England Journal of Medicine, right? They compare, there is this new concept for what's called the learning model, and it's really more, it's right along the same lines as the disease model. It's just saying it's a disease that the brain is learning and adapting. So it's just taking it one degree more, but it's not saying it's not a chronic disease that needs to be managed at the time. It's saying more that the brain is adapting, and it's adapting in a way that sort of is satisfying the need that it has at that moment. It's in survival mode, right? And it's like, I need to do this to survive with a host, right? That's what the brain's job is to do, is to keep the host alive, which is the rest of your body. And it's like, I'll do that, and I'll do it pretty well. And I'll adapt to that to get to satiate, to sort of keep homeostasis in my body. Looking at so addiction really, and I use the word addiction in terms of sort of this place where we've gotten where it's no longer a choice, right? Into this, it's a more advanced phase of the disease. It's not the recreational use. I'm going to talk about the phases in a minute, but we're talking about addiction. Is a pretty decent symbiotic relationship between all of these entities, right? It's the type of substance you use. LSD doesn't have a huge high addiction potential, right? So LSD versus heroin, it's just that it has to do with the agent, right? It has to do with how you use it. I smoked marijuana once compared to I injected 2 grams of heroin. It's a different sort of interaction with the body. So the agent, it itself, how it's consumed, plays a role in addiction. Your genetics, right? The individual's genetics, and this goes a little bit back to the mental health bit. Could it be mental health related? Absolutely, right? Could it be just a low dopamine bit, and I'm less likely to sort of see normal things as awesome, and I need to supplant that kind of gloomy outlook with something that might make me feel better? Sure, right? So that's the genetics. I might have some history of addiction in my family, which I'm not going to go a lot into that, but that's a potential. And it could just be your culture, right? Do you live in a neighborhood where you walk down the street and you see people using drugs? Do people normalize it within your home, right? Do people not only normalize it, but do they high-five you and introduce you to it, right? That sort of thing. The interplay with the environment, the agent, and the host itself all play, I wouldn't say even roles, but relatively equal roles in the whole concept of the disease progression of addiction. Some of the risk factors we'll just go over, right? I put this in here because that graph that I offered earlier doesn't include this, but adverse childhood events and trauma have a lot to do with substance use. And it's sort of the idea is that sort of everything we do for a reason. Period. Right? I drink because it makes me feel better. I smoke pot because it makes me relax. I take opiates because it calms me out. I do it for a reason. It's not like, hey, that made me feel like crap and I don't even know why I'm going to do that again, but I'll do it again. We know what we're doing. We do it for a reason. And a lot of times it's to sort of deal with some of our past history, past trauma, and things that we're sort of trying to make ourselves feel better around or within. The age of first use has a lot to do with it too. That's why they say if you can get an individual to 25, I think it's 25 or I think it's 25, without using a substance ever, they're like 80% less likely to have an addictive disorder. It's great, it's phenomenal. If you can just get them to the point where their brain's developed and they get all these really kind of useful adaptive skills, like how to reduce stress without that, how to have fun without that, you get them to that point, and they're way less likely to have any sort of addiction related to it. So we are going to talk a little bit about where it resides in your brain: the hippocampus, the orbital prefrontal cortex, the amygdala. I want to go on to this though, because we're going to talk about these components real briefly. This is an image and a series of images from the New England Journal of Medicine. They're color coded. And I'm colorblind and I can even follow this thing. It's great. So it really kind of helps you conceptualize who and what part of the brain's driving the bus during what phase of this, what they call this triphasic phase of addiction or withdrawal, right? So we're just going to talk really quick about this binge component. They talk about the binge component. When the binge and intoxication part of the brain is kind of enacted, everything's okay, right? Just everything's okay. And I even actually, at that point, I might even be like, everything's so okay, I have a little remorse in why I even did it anyway, and I promise you I'll never do it again, right? I can, at that point, I can be like, everything's okay in my body, I promise I won't do it. So I don't want to get super into the detail of this. I just want you to, over a 20,000 foot view, like understand that there's 3 different phases, different ones driving the bus. So it's saying, hey, everything's okay. I'm over here, I'm feeling good, right? I'm escaping the feeling bad, which is really, really, really important, especially when it comes to alcohol withdrawal and opiate withdrawal, right? It can be very, 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 very uncomfortable. So the problem is when we neuroadapt, we go from feeling really, really, really good, this is a problem, to just avoiding feeling bad. So I stop doing it because it feels good, I'm doing it because it doesn't make me feel crappy, right? Which is a version of good in that sort of relative way, okay? So this part of the phase, they're feeling pretty good. Then they go to the withdrawal phase. And this is where it gets a little crazy because you've got this little teeny thing called the amygdala, right? It's about the size of an almond, 2 of them. And it's a really, really powerful driver of human behavior, right? So this is where it's like you want to avoid this sort of feeling depressed, anxious, and relentless and restless after a while, right? So once again, you're going from this point where you're like feeling kind of cool and everything's great to, I just want to avoid feeling really crappy. So it's avoidance of the dysphoria once again, okay? And the amygdala it actually has a lot to do, it's connected to the fight or flight bit that our brain processes through. So you're not really using the part of your brain that's making good choices. You're using the part of the brain that says just escape danger, make this all go away, okay? So in this part of the brain, this is where you're like, I'm gonna go get this, I don't care what I need to do. I need to sort of satisfy, I need to not feel kind of crappy again. Even though I told you 2 hours ago, I'll never do this again. I meant it then, I did. But then this part of the brain took over and it's like, I know you meant it then, but not now, okay? So that's where it becomes real tricky. You're like, why are they lying to me? And like, individuals, you'll interact with individuals all the time that are sort of, I swear to you, I'll never do this again. And then a couple hours later, a day later, it's like, whew, and you're like, didn't we have this conversation? And yes, and they were earnest and honest, and they meant it at the moment, okay? And I don't want to minimize how tricky that can be, or how confusing, right? But at least we now know why, right? The brain is just not letting that individual sort of, or that part of the brain, the good decision-making part of the brain drive us. So then you get over to this preoccupation phase, and this could be a double-edged sword, right? Because the preoccupation phase, the prefrontal cortex were saying, hey, make good choices, right? Whatever, good choices, make more effective choices for the situation, meaning maybe I don't use, is actually like saying, how do I make better choices right now to save the host, right? Because it's feeling like real crappy. And it's like, that is like the worst feeling I've ever had. I don't want it anymore. I've got an idea, right? So then the survival part of the brain kicks in and is like, I know how to get that. Just like we did when we were hunters and gatherers, and being like, I know how to get that. It remembers, and it can be really effective at acquiring what it needs to help the host, you, feel better and feel like it's surviving. So this is the current sort of thinking of how those phases happen in the brain, right? We go from, I'm feeling good, I promise I'll never do it again, swear to God, I don't need to do that, or I might not be making that promise, I may just be telling you I'm feeling good, right? Two, I feel real crappy, I need to avoid this. Two, I know how to get that, and then it cycles back to the use pattern again, and it cycles over and over. So, you won't be tested on that, I just think it's kind of cool. So this gets back to why do we use substances, right? And like going back to what we said before, everything we do for a reason. Every single thing we do for a reason. We do it, euphoria, opioids have a massive dump of dopamine in the brain, right? Imagine, right, your life is kind of crappy. Just in every way that you can imagine, it's crappy, and all of a sudden you're introduced to this thing, whatever it is, that makes you feel, quote, euphoric. Kind of makes sense, right? That you'd be like, huh, why wouldn't I try that again? The problem is, most of these substances work really well for a short period of time. And I hear all the time they work until they don't, right? And it works because it makes you feel better. It works because it makes you feel less anxious. It works because it takes the pain away, the depression away, the anxiety away. It works because I can now be more social and I can hang out with my buddies until it doesn't. And the problem is, some brains don't know when to put on the brakes when they see that coming, right? Some are like, whoa, we're getting too deep here. I'm not feeling good. I'm sick of being hungover, or pot costs too much, or I got whatever that negative consequence might have been. And we listen to it, and we respond to it, and we're like, hey, I'm just going to cut back or not do it at all. Some brains don't tell the person to do that, and they continue down the use pattern road, and that's when the disease state starts sitting in. But they're not super fully conscious of when it goes from working to not working, right? When it stops working, that's when we get more into what we call sort of the diagnostic criteria of substance use disorder. That's when, in many ways, it stops working and you see the negative things that are impacting your life, which we'll talk about in a minute. But in the beginning, we use it for a reason. Feels good. Just feels good. I'm going to talk about this slide for a second. So this is a slide we talk about a lot with a concept we call harm reduction, right? And harm reduction is anything that we do in a more safe way. That's it. We're reducing harm of interacting in the same activities we do normally, and we'll talk about this more in a second. But this is a concept that I really would love the world to grasp, that substance use is a continuum. Right? You have over here abstinence, which more than, I think 51% of the population of the world doesn't consume anything. 51%, so that's awesome, right? So no use, all the way over here to addiction, dependency, or what they call in the harm reduction world, the chaotic realm, right? That's when just things are just like, it's just not working anymore whatsoever, and life is so chaotic that it's really hard to sort of maintain any semblance of normalcy. That's over in the addiction, problematic use. But you can see there's a whole continuum, right? There's people that go from nothing to a lot in a huge spectrum in between, okay? So anytime that we can, when we talk about treatment, anytime we can get someone to move in this direction, right, that's a win. That is a win. It doesn't always have to be, this might sound counterintuitive of me being up here, it doesn't always have to be abstinence. It doesn't always have to be no use whatsoever. Less use is a win, right? So hopefully, like therapeutically, what we hope to get is less use feels better, and you're like, huh, maybe I'll try that on again and do less. Yeah, maybe do less a little bit more. That's the hope, right? Because it doesn't, we know like just stopping something completely doesn't typically work for most people. That's why relapse rates, right, reoccurrence rates are so high. Like the average person is like 15 times they relapse in recurrence use. Yeah.
When you talk about abstinence, do you know the number, like the percentage of abstinence growing or increasing?
Worldwide, I don't, and I don't have that even nationally.
I just wondered.
Yeah.
And I also wondered if there was a way to know what percentage of abstinence is abstinence after treatment, like a conscious choice for abstinence because of harm reduction as opposed to an overall choice for abstinence
This data,
without use.
the 50% data that was a NIDA survey, and that was no use ever.
No use ever.
Yeah, that was, yeah, exactly. And that was part of a screening, brief intervention, referral to treatment, and expert model. Long story, but it talks a lot about sort of just, normalizing use behaviors. And kids normalize it because they're like, everyone's doing it, right? And you do surveys of high school students and they're not. But they, like the ones that are in it, and that's their environment. So those are really kind of helpful conversations to have with teens, especially being like, not everyone's doing it. They might seem it because in your little microcosm, everyone is, but in the bigger picture, which they don't do very well yet, right? Everyone's not. Actually, the majority isn't. So,
Just curious what, as we progress in treatment,
Yeah.
how it will impact abstinence.
what do you mean by that?
I guess whether it, not abstinence never use, but whether, whether we'll start to see an entire trend
Sure.
kind of going back in the direction of, maybe less use.
Sure.
Kind of
No, I mean, like, I'm seeing a lot of high schools have no-use clubs. It's really cool, right? Because they start out kind of not pulling any punches. They start out being pretty dorky, and people kind of like, but then they normalize, and kids are like, that's pretty cool, York High School's got a thing called tidal waves, and it's amazing. It's absolutely amazing. These kids are like, they take this pack, they're like not doing it. It's not straight edge like that hardcore 90s thing that people might have heard of. They're just kids that are like, I'm not doing that. And they choose to, and no one makes fun of them. And it's just a really kind of cool culture. It's a counterculture in a way, that I think is really exciting, because we are seeing a lot more kids that are just overtly, not just innerly saying no, overtly they're like, I'm not doing that, which is quite a statement. So I don't want to talk like a tremendous amount of this either, but we do know that the reward pathway plays a huge role in using, right? To the point where these were our primary survival bits earlier. It was like eating, drinking, procreating, sex, and protecting myself. Those are the things that I'm like, you know what? I, as this creature that's been evolving for a long, long time, I've evolved as these are three primary drivers, okay? And unfortunately, we get to the point where that reward system overrides that in terms of behavior, and the substance becomes the primary drive factor, right? And this is really kind of heart-wrenching when you see a mom who just delivered a baby, right? Oxytocin is coming out, she's ready to sort of feed the baby and engage with the baby, and she's simultaneously having a craving for opiates, stronger than anything. And you're like, wow, those two primal pulls, right? I just think that's such a fantastic example of the primalcy of this, like being like, I've got to do this, I've got to provide for this thing that I just brought into this world, and that secondary driver being like, nope, you got to go get this because it's more important. And that conflict that happens, right? So that's just an example of how massively influential, right? Whoops, this can become. So it's not just going back to the, oh, if you just made better choices, right? Oh, that would be great. That would be fantastic. It's not that simple. So real quick, dopamine dumps in the brain, really small with food and sex, really. Well, relative units will say, I think, what do they say here? Like 150, right? Compared to cocaine and methamphetamines up in the 1500s, right? So what people consider as feeling good, you just can't compare to that anymore, right? If a good burger and a cigarette and sex is 150, but methamphetamine's 1500 units of feel goods, right? You just can't compare with that. You can't compete. So that's like why methamphetamine specifically, especially utilized IV, is such a massively sort of addictive substance because it floods the brain with this massive euphoria, and then, you know, you're sort of on your way toward that. So, one thing that we know, right, when we see addiction as a chronic disease, we know that we don't cure it, we manage it, right? Diabetes, we don't cure diabetes, we manage diabetes with diet and exercise, right? We don't cure a lot of chronic diseases that medical doctors see all the time. We don't cure them, we manage them. We live with them, we learn how to navigate the world with them, and we even have remission, right? And we even have relapse, right? We can do. Cancer came to have a relapse. Diabetes, we can be like, oh my God, my A1C was managed for a while and now it's not. That happens all the time, right? And in the medical world, we even expect it. We're like, oh, yep, their A1C is up again, it's over 9, come on in. You know, we'll make some adjustments. But when we see someone in the medical world sees someone that like has a reoccurrence of use, they're like, oh my God, what are we gonna do? You know, it's like this big, huge sort of to-do. And it's like, what if we just saw it as managing a disease and it wasn't, oh my God, it was a, hey, let's do this, right? Because we have treatment options. So this is where we're going treatment-wise, is we're trying to have the world see addiction and substance use in its chaotic form as a chronic disease that has to be managed over a lifetime. So,
Can I ask a quick question?
you sure can.
So I think that's an important point that you make, but someone could overdose or die and affect their whole family. Yes, you could pass away from diabetes, but is it the same? You know what I mean? Like normalizing it, but like if someone overdoses and they leave a family behind or they cause a car accident, you know, do you do that with diabetes necessarily?
Well, I think the disease, what the disease model of addiction doesn't represent well is the consequences of individuals' behaviors, right? It doesn't. Like a consequence of a diabetic overeating cupcakes is like my A1C's high, right? And if I do that chronically, right, I could have an amputation and it could drastically impact. I could actually, I mean, you know, maybe DKA, it's called, right? Diabetic ketoacidosis could go into that and I lose consciousness. I could have an accident, hurt someone. But the repercussions of sort of behaviors around substance use, I don't think we sort of have really grasped yet in the bigger picture, because you're right, someone could hurt someone else. A DUI could hurt someone else. An overdose, right, could hurt someone else. So I think, I don't know if that would change my way in how I see treating it. I think that would change the way that I would promote treatment for it, because it's such a necessity. 106,000 people died, right? And we're still like, hey, let's just get Narcan out there, that's enough. Right? We're like, wait a minute, why don't we have more treatment centers, right? Why aren't we making this a priority? So I think, now that you bring that up, if we saw it more consequential than we are right now, maybe it would be more urgent in people's eyes, and they'd be like, hey, we really actually have to do something more than just get Narcan out there. So, yeah.
I was just thinking, my brain's just like going.
Sure.
Has there ever been studies done like with teenagers who maybe had been experiencing anxiety, but then they get just put off and then they go off to college or go on after they graduate and then end up using? Like there's a correlation with that, like misdiagnosing, not actually treating that?
They're mixed. A lot of those studies are mixed. I couldn't quote any of them. I know there's a lot of studies, sort of, and maybe Dan, you could when you talk about this. There's a lot of, I don't know where they stand actually, but maybe 10 years ago there was a lot of mixed reviews on prescribing stimulants, and did that cause an addiction later on, if you did it earlier or not. But I don't know of any studies regarding that. So
Just like curious, you know, just
Sure.
like thinking, because I know my own son had dealt with anxiety and stuff in high school, it was put off.
Mhm.
It's just, he's being a teenager, it's being missed, and then it got to the point that last year he OD'd. And thankfully, he got treatment and he's
Right.
doing wonderful. But it's, so that's just like in my,
Sure,
Yeah,
and I think one of the, and this is where the statistic, if you can get them to 25, that's with the caveat that they learned somehow or been exposed to or learned coping skills that were effective for what they're dealing with, right? So if it's anxiety, how do I cope with my anxiety, whether it's medicine, whether it's healthy lifestyle, whatever those things are. If those are 100% in place or more in place, then we're less likely to replace them with something that over here, there's a drug. So, treatment of addiction. We do know that the treatment of chronic disease is the management of, right? We want to decrease frequency of relapse, decrease the severity of relapse, and increase the duration of remission, right? And we just want to, overall, if we do that, we optimize their function. And to do that, though, right, we need the ability to access treatment more often. If an individual went to their doctor's office and said, hey, my A1C is 12, and the doctor said, well, you know what, you got 2 weeks, we can see in 2 weeks. Could you imagine that? Right? But we do say, oh my goodness, I was on buprenorphine and I had a reoccurrence, and they're like, and I need treatment. I was like, well, it's a 2-week wait, sorry. You know, just go around. And this is the part that, like, I want to be very clear here. Really what we're saying is, it's cool, because fentanyl's in the opiate stream, right? You use opiates every day, so every day when you inject that, you have a chance of dying. That's okay. That's what we're saying, right? I mean, essentially, and I don't mean to, I'll just say it right now, that's essentially what we are as a system, where that's what the message we're giving, that we wouldn't give to other disease states.
They're giving out test strips now.
Fentanyl test strips, yep, wonderful. Yeah, no, well, I mean, it is.
It is.
Yep.
It is.
Yep. They are considered contraband, unfortunately, according to the state, right? But you're like, great, you know. But you can still give them out, but they haven't really, aren't going to enforce that. The legislature's so ridiculous that they just haven't been able to sort of reverse that. Paraphernalia, that's what it's considered. They also have xylazine strips that we can distribute now. If you're an SSP, which is a sterile syringe program, you can hand these things out sort of that can help individuals sort of hopefully test their product before using.
So when you say they're considered paraphernalia, what's the repercussion on someone?
It's a leverage thing, really. So if they were like, I want to get you for something else, I can.
That's right. Opens the door.
Yeah.
Wrong.
Yeah.
That's really wrong.
So we're going to talk really brief about 15 minutes. So I want to talk really briefly about diagnosing a substance use disorder, right? This goes back to the whole continuum. Way over on the left-hand side, right, we had no use abstinence, then it continued to a little bit, maybe here and there, to moderate, to, ooh, it's getting a little bit more to chaotic use. Okay, that's the continuum. The DSM, which is the Diagnostic Statistical Manual, number 5, for psychiatric disorders, made diagnosing substance use disorders relatively easy. Okay? They give you these 11 symptoms, right? If an individual is experiencing 2 of those symptoms, they have a substance use disorder mild. If they have 3 to 5 of those symptoms, they have a substance use disorder moderate. And if they have 6 or more, it's a severe, right? So it's a pretty straightforward diagnostic process. The difficult part is understanding sort of what this really means in human behavior, sitting with them, talking with them, and teasing out that sort of detail. But diagnosing it is pretty easy, you know, in the end, if you know how to do that. And you'll see a lot of these needing more, developing withdrawal, spending more time, neglecting responsibility, continued use, giving up important. All of these things are when that brain stops being like, hey, let's not do this, to it's no, I need to do this. So it's more and more and more of the negative consequences and the sort of the negative efficacy, I would say, because like we said before, everything we do for a reason. Well, it stops being so effective, but we keep doing it. That's when this becomes more diagnostic, okay? I continue to use even though all of this other bad stuff is happening in my life. Okay, so now that we talked about that, we talked about diagnosis, talked about the brain a little bit. What I'd like to talk about now, I'm going to weave 2 concepts together. One's called the trans-theoretical model, otherwise known as the stages of change, right? And the other is just the ASAM levels of care. I'm kind of just going to weave them together because I think it's important for all of us to know what level of care and what intervention we do at what stage of change an individual is in. So before I go any further, these are the 6 stages of change. Prochaska and Di Clemente, sort of back, I can't even think of the date. If you know it, tell me, I apologize. And they've been kind of revising the concept ever since. The idea really is that every change that we go through, everyone goes through every one of these phases. Whether you know it or not, whether it's a blip or not, we all go through all of these phases, and I'm going to talk about them a little bit more in detail. So, this one, the first one, pre-contemplation. Okay, pre-contemplation is I don't even want to. Right? So it's not I don't want to, because that's, you've thought about it, I have a want. I don't even want to. I'm before that even happens. It might be due to my views of the world, my view of self, view of the future. It might be because I'm unaware. It potentially could be because I'm not looking at it on purpose, right? But I don't even want to do it. It's pre-contemplative to myself, any sort of behavior change, don't want to hear it. And actually, if you do tell me about it, I'm probably going to tell you to zip it, or I'm going to tell you it's not a problem, which, according to motivational interviewing, the more and more you get them to deny the problem, the more real it becomes that it isn't a problem for them. Right? They entrench, they fight for the defense of their own situation. So you're like, well then what do I do? So if they're in the pre-contemplative realm, you simply say, I understand this is no big deal to you right now. If you need anything, come on back. And you have to be able to, that's a hard thing as a parent, right? You're being like, no, there's a flipping problem here, we're going to take care of it. And I'm not telling anyone how to parent. Conceptually, though, we know what happens when you tell a teen, do this. What do?
They don't do it.
Right. You pull on the 2-year-old's hand, what do? They pull back, right? We do the same thing, we're just more sophisticated in how we pull, right? We're like, yeah, whatever. So, pre-contemplative is a very, very tricky phase to sit and wait in, especially for helpers. Helpers want to help, and helpers are like, I'm going to help you out of here, even if you don't want it. And they're like, that's when they're like, I'm out of here, and they want to run away because they don't want your help, right? So, pre-contemplation is really hard for helpers to kind of exist in and do nothing in. Talk a lot to nurses. Any nurses in here? Love you guys. My mom, grandmother, 2 of my sisters, all nurses. They love to help, right? They even, motivational interviewing calls it the writing reflex. I'm gonna write that. I wanna make it better, right? And that's why they get into that field. In pre-contemplation, that's not your job, though. It's not anyone's job, right? Because we can't write that at that moment. So it's really hard to be in. So what we do is we offer harm reduction concepts in pre-contemplation, right? And remember, harm reduction is anything we can do in a safer direction, right? We don't not ride bikes, we wear helmets when we ride bikes. We don't not drive cars, we wear seatbelts, okay? Same thing with drug use. We don't say don't have sex, we say wear a condom, right? If you can use the nicotine patch instead of smoking a butt, that's harm reduction, right? If you can use buprenorphine instead of heroin, that's harm reduction. If I can give you a sterile syringe so you don't use a crappy old one you've had for 4 weeks, that's harm reduction, right? So it's any direction that we can get an individual in to do what they're doing in a safer way. This is a really hard concept for some people because they're like, you're giving needles away? You kidding me? It's like, yeah, we are. Because if I can give an individual 10 sterile syringes so they don't get an abscess, right, have to go to ED and they now have sepsis, that's a harm reduction. Did I do anything to reduce their heroin use? Maybe not. But at least they didn't die from an infection, right? So dead people can't recover. So that's a motto I kind of like to live by. You know what I mean? If we can help people stay alive, that's great. So anyway, these are some harm reduction concepts. I'm going to go to this slide and the next one, then I'm going back. So handing out a lot of people, you'll see New Hampshire Harm Reduction Coalition, a lot of sterile syringe programs. They literally help people use safer, right? And they're giving out clean product. The idea behind an overdose prevention site where an individual could use illicit substances under the observation of a medical professional, that's harm reduction, right? That's if they do overdose, someone's there to help them. They're not giving them drugs. They're just being like, if you're gonna do them here, so if you die, I can bring you back, right? So These are some other things that we do, harm reduction kits. We do a lot of wound management stuff, just giving out Band-Aids and ointment and clean socks and just being like, hey, I hope you're as sterile as you can be in the world you live in, because I know it's kind of a crazy, dirty, chaotic, maybe world out there. Maybe this stuff can help you, just be a little bit safer. Now I'm gonna go back here though, because this is something I don't think we talk enough about, is this concept of conversational harm reduction, right? Conversational harm reduction is using person-first language, right? You're an individual with a substance use disorder versus a junkie, right? Can you see where I just reduced harm by changing my words? So the interesting thing about how we choose to speak is how we speak influences how we think, and how we think influences how we feel influences how we act, right? So if I talk different, if I call you a person first something versus a junkie, I act different. So it changes everything across the spectrum. So this, I don't think there's enough to be said about how we use our words. That old saying, sticks and stones can break bones, names will never hurt me, that's BS, right? Because we do know that sort of the language we use heavily impacts people, right? Big, huge rocks that come flying out of nowhere, that's the kind of stone we're talking about with words that can really hurt. So on the other end of that is harm reduction language. And we're going to talk a little bit about that. These are the fentanyl test strips. So if you want to see what they look like. Someone said to me, I'm joking a little bit because this is morbid humor. They're like, you don't pee on them, do you? I was like, no, because that would be after it's in you, right? So that's what do they call it? Gallows humor, maybe that's what happens when you do stuff for a long time. But no, you don't pee on them. You dip it in, you use a little bit of the substance, put it in water, mix it up, dip it in, test it. So that's how it works. Conversational harm reduction, right? Individuals that are struggling with substance use disorder carry their own guilt and shame. We do not need to make it worse. Okay? That's not our job. They're doing enough of that on their own. Remember we talked about that pre-contemplation bit. This is the role when we're like, you may not want help now. When you do, I'm here. Right? So behaviorally, I don't want to get into sort of how, I don't want to be like, is that enabling behavior or not, or how do I help this person about, that's a dissertation all on its own. All I'm saying is if they're pre-contemplative within a certain realm, when you're ready, I'm here. That's the message we give. Okay, because they've got enough, their shame and guilt are bringing with them. This is a really interesting thing. I suggest reading this book, Dignity. It says research suggests that we are just as programmed to sense threat to our dignity and self-worth as we are to our physical threat. If someone came up to you and threatened you physically, what would you do? Run? What else?
Walk away.
Walk away? What else? Defend yourself? What else? Yeah, right? You're like, the hell with you, no way I'm protecting this. Research shows that people protect their dignity in the same way. Think about that. Their dignity. How do you protect your dignity? Right? What does dignity mean to you? So if we jeopardize someone's dignity, they're gonna fight, run, or they're gonna do, or hide, right? They go quiet. They're going to do that. So it's a protective mechanism. Interesting thing is, conversely, we are programmed to re-engage if someone preserves our dignity, right? Because we are social creatures. We want to be connected. We don't want to fight. We want to be protected. So if you're like, no, I value your dignity, I want to be part of this, then they're like, okay, I'll come back in the circle, right? So dignity is really, really, really important. You can preserve that a lot by just simply utilizing person-first language when you engage with someone. They are an individual person with a substance use disorder. Medication as treatment. They had a setback. They maintained recovery. All of these things. We're used to using person-first language, right? It's not new to us. We're used to using it. Now we just got to shift it over into sort of the substance use world, and it follows suit, right? Would we ever say to a diabetic that they were a junkie for sugar? Right? We wouldn't. Would we say that they had a dirty blood screen because their A1C came back high? Right? No, because you're like dirty. You know, that doesn't make you feel good. Dirty what? What's that mean, right? So it's just a positive screen. It was a positive test, period. So we can normalize things just by the words we use. These are some other sort of examples of positive active words that we can use. Instead of struggle, suffers from, they struggle with, refuse to take, they decided against, right? Didn't keep in an appointment, they weren't able to be here, right? We underestimate how busy other people's lives are, and we overestimate our own importance, right? Doctors say they no-showed me. Oh, you're so important, right? You get to a whole verb just for you. You get to get no-showed. What about all the things that are going on in their lives, right? So you all have been busy. You all have been in a chaotic world. You know it. They're not non-compliant. They just haven't seen the value in it yet, right? You can totally see, not only, in my mind, I think, I see this as also making me feel better, right? Because it's no longer a slight against me. They no-showed me. It's like they had more important things to do.
There's a sense of understanding in that statement.
Totally.
And
Yep.
I can't stand the non-compliant.
Yep, absolutely. And this one too I love. They didn't arrive late. They were just determined not to miss. And you just twist it a little bit. And that's not Pollyanna. That's just a slight twist of sort of the reality. It's all about perception, right? Because that's really what we have. I think we have 2 minutes left. So I'm going to talk a little bit more. How many minutes?
2.
2, okay. So contemplation is the next phase, right? That's when they're wanting to. So this is when you really start working on exploring opportunities with them, right? And you're talking about sort of how important it is for you, how confident are you that you can pull this off. That's what happens in the contemplation phase, because you want to get them, you don't want to push them back into pre-contemplation, you want to sort of help them move into action. And the more you can get them to talk about how confident they are about that change, and how important that change is to them, the more likely you are that the change will happen. Simple. That's what all the research about motivational interviewing says. Get them to talk more about the confidence and its importance, and it will happen. Then you get into the preparation phase, and that's when you get into action. I am going to show you all this real quick. When we talk about treatment, right? Does anybody know what rehab means? What's rehab mean? When you say I went to rehab, what was her name? Oh God, I forgot her name.
Amy Winehouse.
Hey, yeah, Amy Winehouse, right? I'm not going to rehab. So what's that mean? What's rehab?
I think rehab is you're working on something, you're trying to get back to where you were, whether it's addiction, whether it's recovering from a brain injury, whether it's recovering from surgery.
It's a process of recovery.
Right.
Yeah. In the substance use world, typically it's an inpatient setting, right? And according to the ASAM levels, they're up in the 3s and 4s. And you go off to an inpatient setting to remove yourself from the setting you're in for certain reasons, whether it's medical reasons, whether it's I don't have enough recovery skills to sort of avoid using, whether I'm homeless living under a bridge, and of course I might use if all my buddies are in my tent back there or using, so we got to remove you because the environment isn't safe. Potentially, that's where an inpatient setting could come in, and those are level 3, okay? They could be 2 weeks, they could be 3 weeks, they could be 90 days, they could be 6 months, depending on sort of a lot of different factors. But that's what, when you hear someone went to rehab, it's typically an inpatient setting from 2 to 180, well, 2 weeks to 180 days. Everything above that, all the 2s are group setting, right? So there are levels of care that are groups every day, all week that you go to, right? For a more exposed therapeutic experience. And then the level 1s are all individual services. There's a lot of people in Stratford and Rockingham County, see all these level 3s? They don't exist. So if we say to someone, we want to treat your chronic disease like diabetes, how come we don't have treatment? We have counties that don't have levels of care, right? So we can't provide like streamlined care for individuals, seamless care, if we don't have enough beds for individuals to be in, or enough rehabilitation spots. So I think this is why I put this in here, because I know this is my job and this is what I do, but as a layperson, you can look at that and be like, wait, there aren't that level of care in that location, then how do they get care there? The answer is they don't. Right? So that's the kind of the disruption I want to make here, is that you all understand that the state of New Hampshire just doesn't have enough treatment options within our state, and if there's anything you can do. That'd be awesome. Then you get into action. But we're all done, I think. We have lots to talk about, if you could imagine. But we're gonna end here because we're in the action phase, and this is really when you're just being encouraging, and you're like, hey, I'm here again. If you need anything, let me know. Okay? Thank you all for being here.